You alluded to this earlier. Wouldn't insurance companies try to stop all these surgeries if they weren't necessary so they wouldn't have to pay for them?
Yes, and they are. So health insurance companies put a lot of effort, lobbying money, research money, into trying to find out whether these operations work and trying to change practice where it doesn't. And in the US, they tried to stop doing spine fusions for back pain. In Australia, they tried to stop that as well, doing spine fusions without a clear diagnosis of what's going on. In Australia, they got that overturned. I think they worked their way around it in the US. And so surgeons are still doing it. It's difficult to create rules that are that strict without saying you can never do a spine fusion. Because there's cases, where the spine's been broken or dislocated or something, where a spine fusion is a great operation, or somebody's got cancer in their spine and unblocking the spinal cord and fusing the spine might be very helpful to the patient. So there's examples where spine fusion as a technique is useful or might be useful. So they can't wipe out spine fusion. And so then it just sort of leaves it, makes it difficult to get around. It's a bit like the knee arthroscopy debate. What happened was we used to do knee arthroscopies for people with pain in the knee. And a lot of that was arthritis in the knee, degenerative change in the knee and arthritis. And we would give them a washout or an arthroscopy. And then the first placebo studies showed that that didn't work for arthritis. And so the surgeons kind of changed the goalposts a little bit, and they said, well, it's not really arthritis we're doing it for. We're doing it for the meniscus tear, the degenerative meniscus tear. And so the next placebo study showed that surgery specifically for meniscus tears wasn't effective. It was no more effective than placebo. And so surgeons sort of changed their tune and said, oh, well, it's not so much the meniscus tear on its own, it's the mechanical symptoms that the patient has. They're the ones that really benefit from surgery. And then they looked at more studies and found that even those with mechanical symptoms didn't do any better with surgery compared to placebo. And so people keep changing the goalposts, and it's the same thing with back pain. They're kind of like, oh, well, it's not really the degenerative changes that we're treating, it's the instability, or it's not the instability, it's the alignment. They keep sort of making up reasons as to why their operation might work, and what they're really doing is looking for explanations as to why some people get better after surgery. And they're not considering the placebo effect of surgery or the fact that other factors might be affecting their improvement. When in fact, I think the surgery is probably not effective.
So our next question is why do some doctors think their surgery is more effective than the data suggests? I'm hearing an answer in there. Is there more you want to add to that?
Yeah, to sum it up, I think that doctors are more influenced than what they see in their own experience than what the science would tell them. And so if 2/3 of their patients say they feel better after surgery, most surgeons attribute that improvement to their surgery. And that's a logical fallacy called post hoc ergo propter hoc, which means it follows, therefore it is because of. And so when they see 2/3 of their people get better after their knee arthroscopy or their spine fusion, they think that those people got better because of the surgery. And we know, though, that 2/3 of the people would have got better if they'd have done anything else to them as well. And that's the problem. People can't see past this very powerful human response to see causation where correlation exists, and that they want to see causation, and so they do. They see causation. They see that the improvement is due to their surgery, but scientifically, when we look at that, it's probably not the case. And so it's an illusion.
You said most surgical procedures have not been subjected to blinded trials, which is the least biased measure of effectiveness. And that's what we need to change. Why haven't most surgical procedures been subjected to blinded trials so we learn once and for all which procedures are and aren't effective and safe?
One of the reasons why surgeries have not been subjected to high quality comparative trials is because they don't have to be. So if we wanted to introduce a new drug, we would have to compare it to the best available drug or a placebo drug, or do a high quality randomized trial to find out if it works. That's the only way we would get that pill on the market. So the only way we would get the insurance to cover it, to make it common practice. But you don't have to do that in surgery. You just have to say, it sounds like a good idea that if I take out this lump, or if I fuse this spine, if I take out this torn cartilage or whatever, that the patients would feel better. And hey, I've been doing it for a while and the patients seem to like it. That's all you need for surgery. So one of the reasons why we don't have that evidence is because we don't have to. I think a lot of surgeons aren't interested in getting that evidence because they're happy with the way things are. If they were forced to subsequently be paid for that operation, then I'm sure we would generate a lot more evidence.
Why was it important for you to come speak with us here at the Real Truth About Health conference?
For the same reason I wrote the book. I want to get this message out to the widest audience possible. And so I thank you for the opportunity to do that.
Well, we thank you for your very meaningful work, and for joining us as well. It means a lot to us and to especially to our audiences. So thank you. Thank you for your time today. Really appreciate it.
It's been my pleasure. Thanks.
Be well. Take care.
Okay.